Hello, welcome to Stanford Care's monthly community health talk series. My name is Robert Huang, and I'm going to be your moderator tonight. I'm pleased to bring you this series of talks co-sponsored by Stanford Care, Stanford Health Library, and the Vincent V.C. Woo Memorial Foundation. I'm very pleased to welcome Dr. Yanghee Woo, who will speak on achieving health equity in gastric cancer among Asian Americans. Gastric cancer is the third leading cause of cancer death worldwide and is diagnosed in 27,000 Americans each year. In the United States, this burden falls disproportionately on ethnic minorities and immigrant communities, particularly Asians. There is currently no coherent national strategy for the early detection or risk mitigation of gastric cancer, even among identified high-risk groups. The under-recognition of gastric cancer among minority communities may be one of the most significant unaddressed healthcare disparities in the United States. This presentation will focus on gastric cancer as a leading cancer disparity that adversely affects Asian Americans. It will cover the difference in gastric cancer risk, incidence, stage and presentation, and treatment outcomes among the richly diverse subgroups of Asian Americans. Additionally, we will discuss how to address this health inequity in the US. What can we do as members of the physician community, as members of the larger ethnically diverse society, as researchers promoting science and cures for a not so rare cancer, but with very low NIH funding allocation? Yanghee Woo is an internationally recognized surgeon scientist with expertise in robotic surgery and gastric cancer. At City of Hope, she leads a high-volume gastric cancer practice offering advanced surgical treatments, including robotic gastrectomy and lymphadenectomy. Dr. Woo is a professor of surgery, vice chair of international affairs and community outreach, and director of minimally invasive therapies at City of Hope Comprehensive Cancer Center. She spearheads the transformative gastric cancer program and leads research efforts to eliminate gastric cancer deaths. Her research includes identifying immune biomarkers and integrating novel surgical technologies, and she is supported by funding from the NIH, the Department of Defense Cancer, and the Cure Foundation. It is my great pleasure to welcome Dr. Woo tonight.
Thank you, Dr. Huang. Thank you for the great introduction. It's my privilege to be here. I have to say that I am not related to Mr. Vincent Woo, but I am grateful for the funding to be able to participate in this presentation. So let me share my slide. So we'll talk about, as Dr. Huang said, gastric cancer in Asian Americans. Just to give you a little bit of background why this is important to us, as I am an immigrant, and so talking about at-risk populations, 1.5 generation immigrated from the country that has the highest incidence of gastric cancer, and I was 7 years old, and these are sort of my training here, and mostly been focused on gastric cancer care and globally and locally. Like Dr. Huang said, I'm an Asian American robotic gastric cancer surgeon. I spend most of my time in surgery and half my time doing research. So I want everyone to be aware that if you are not, November is Stomach Cancer Awareness Month, and stomach cancer, aka gastric cancer, is one of the most health inequities that affect the Asian American community. So I wanted to just start by talking about what is stomach cancer for some of us who may not know, and what should we know about it as Asian Americans and those who care about Asian American communities. So as Dr. Huang stated, that it is a very common cancer worldwide, disproportionately affecting Asians and Asian Americans. And even though it's considered a rare cancer in the United States, it is actually a very common and deadly cancer in Asian Americans. I want to make sure that what Dr. Huang does as a gastroenterologist is to detect gastric cancer. So gastric cancer, stomach cancer, is detectable in early stages, but it requires an upper endoscopy, and I'll talk about why this is necessary. It is curable when diagnosed in early stages with endoscopic resection, surgery, plus or minus chemotherapy. but it remains deadly in the United States because most of our patients are diagnosed in advanced stages of presentation, and it is the leading cause of one of the leading causes of cancer death in Asians and other ethnic minorities. So gastric cancer it occurs in the stomach. There's a picture of the stomach, and anywhere in the stomach it can occur. It's a complex and clinically very heterogeneous malignant tumor. And what we talk about today is adenocarcinoma, which is about 95% the most common type of stomach cancer that we talk about. If left untreated and it's not detected in early stages, the cancer starts to grow through the walls, as you can see here, invade the layers of the stomach wall outward, and spreads diffusely throughout the layers of the stomach. It can spread to lymph node and other organs. And when it goes to these other places, the cure is very difficult to achieve. Two main histologic types of gastric adenocarcinoma: the intestinal type, which the Asian community mostly talks about, but Asian Americans are also affected by the diffuse subtype, which is usually very poorly differentiated and can be diagnosed often in very late stages. We have done a really great job in the past decade, in the last 10 years, to understand stomach cancer better. It's not just about where it's located, where how, like the two subtypes histologically, but we know the molecular characteristics. And this actually helps us to identify some treatment options and understand the prognosis of our patients. And this has been an ongoing effort that's a global effort, and has provided much information, but still is not found the cure yet once it's in advanced stages. We also know that tumors grow in a very dynamic immune tumor microenvironment. When you hear about immunotherapies, all of these novel therapies that are coming out, it is by studying these biomarkers and immune tumor microenvironments. But this is mostly for advanced cancer patients. And at this stage, we still don't have a cure, despite the fact that there's so much science behind what we're doing. So as Dr. Huang mentioned, it is a leading cancer burden. And so what is happening with stomach cancer worldwide? Well, if you look at the incidence rates over here in this box, you can see that if you live in Mongolia, Japan, South Korea, these are the countries where the incidence of gastric cancer is very, very high. So if an immigrant from these countries, you also carry a high risk of stomach cancer. And you can see that the death rates are also high in these countries because early detection is very rare in these countries as well as in the United States. So just looking at the rate. So we know lung cancer is, the leading cancer worldwide. If you look at the United States, you could see that actually prostate cancer, breast cancer, lung cancer, colorectal cancer, and then way down at the bottom of the list, number 15 is stomach cancer. And this is for all of general American population. But if you look at what is happening in Asian Americans, men and women, it's not a rare cancer, and it's among the top cancer incidents. So if you look at stomach cancer, it's the 4th most common cancer in men, and I believe the 5th most common cancer in women. And if you're Korean American, it is the leading cause of cancer, along with lung and colorectal. So it just in summary, if you're an Asian American listening to this, your chance of getting stomach cancer is 2 to 13 times more likely than your non-Hispanic white American friends. And what is the risk factor? A lot of people ask me, what is the risk factor? Like if to develop stomach cancer. Well, you're more likely to develop stomach cancer if you are older than age 40. Older you get, the higher the risk. If men are twice as likely to develop stomach cancer, and Asians are highest risk, and then Hispanics and Blacks and whites. H. pylori infection. If you have an ongoing H. pylori infection, studies have shown it can be up to 8 times the risk of anyone else who has not had an H. pylori infection. And we can talk about mitigating some of the risk by treating H. pylori. If you have it, we know we can treat it, and that will decrease your risk. Smoking and alcohol. So I just learned recently that, the reason alcohol dehydrogenase is the enzyme that breaks down the alcohol. So if you don't have it, you turn flush, you drink a glass of wine and you turn into the color of the red wine. I had a few friends like that. Well, the alcohol dehydrogenase deficiency can contribute to, if you drink alcohol, to gastric cancer. And of course, we've always heard salty food is bad for us. It's bad for our thinking, our memory. Well, it's also really bad if you have a lot of salty foods and smoked food. That increases your risk of stomach cancer. Fruits and vegetables are good for us. As we know, it also is healing in terms of our stomach, and so it decreases our risk. Low socioeconomic status, family history of gastric cancer, immigrant from high incidence nations, and some germline mutations can also increase your risk. These risks are a little bit different from the tumors that occur in the proximal stomach. I won't go into it here, but they are different. And in the Asian American community, CDH1 mutation, which is the cause of hereditary diffuse gastric cancer, the other type, not the intestinal caused by H. pylori, is actually very uncommon, this CDH1 mutation. But I wanted to just bring this to your awareness because there are Asian American families with CDH1 mutations, and that gives you a very high risk of developing both stomach cancer in your lifetime and female patients with lobular breast cancer risk. And so just to put that out there. So in the United States, you could see that 15.5 years of life is lost to every death due to gastric cancer in general. But women have higher life years lost. And if you look at non-whites, Asians, ethnic minorities, have a higher life years lost due to one gastric cancer death. And so we know that survival is based on stage, and early stage means you can be cured most of the time. If you have any of the advanced stages, like stage 4, your survival, where stage 4 is when the cancer has spread to other parts of the body, not including the lymph nodes, like other organs like the liver and the bone, lung, that means your survival is about 5 to 6%. And while the overall survival of stomach cancer has improved, the survival for a very late stage has not improved. And unfortunately, majority of the patients in the United States do get diagnosed in late stages. So just again, the death rates in Asian Americans, men and women, are twice or 2.5 times more likely than our non-Hispanic white friends and counterparts. So if you hear it's 6.3 versus 3.1 in men, and then it's 4 versus 1.6 incidence. And so the death rates are higher. And if you look at the subcommunity, so all Asian, there's, over 20 different Asian languages, countries that we come from. Amongst the Asian Americans, there are more differences. So Korean Americans have the highest early stage stomach cancer diagnosis in California. Looking at the disaggregated data, we see that Hmong or Cambodians are most frequently diagnosed very advanced cancers and have the highest risk among Asians to die from stomach cancer. And this is compared to non-Hispanic white Americans. Looking at the California Cancer Registry again, you can look at the very specific Asian subpopulations with early stage. ECG is early stage gastric cancer. EGC is early stage gastric cancer. Advanced gastric cancer stages actually highest, if you could see, in the Filipino population. And then stage 4 Koreans are least likely, and Hispanics and American Indians are most likely to be diagnosed in advanced stages. And advanced stage diagnosis means poorer outcome and a decreased survival. This is clear. Then why is early detection so hard, and what have other nations done? Well, early stage stomach cancer diagnosis often missed in early stages because early stages are asymptomatic. It's found that 80% of patients with early stage gastric cancer actually have no symptoms. And even some patients with advanced stage gastric cancer really don't have any very specific symptoms. Atypical symptoms like coughing may be possible, like anemia, weight loss, and dysphagia, which is classically associated with the alarming symptoms of stomach cancer. Less than 5% of patients are present with these, the trifecta of symptoms. And advanced stage can also be asymptomatic, but often people get fatigue, weight loss, bloating, abdominal pain, decreased appetite, nausea, difficulty swallowing, severe acid reflux that won't go away, melena, which is dark stool, and early satiety, meaning you get full very quickly. So the duration of symptoms at the time of diagnosis, 40% is less than 3 months before they're diagnosed. But it's startlingly it takes up to 12 months for the other 40% to be diagnosed. And some patients have symptoms for over 12 months and either do not seek care. So why are there delays? Well, patients just ignore their symptoms. We're too busy working. We don't know about stomach cancer symptoms, so we ignore them. We go to the doctor and we get treated for reflux for a long period of time before an endoscopy is offered. And because if you have like some dark stool or abdominal pain, they may offer you a colonoscopy because they say, oh, you're 45 years old, you haven't had a colonoscopy, you should get it, and then don't realize that you're at high risk. And sometimes, unfortunately, dismissed by doctors. So we're all at risk, at fault. But upper endoscopy is also needed for early detection of stomach cancer. It is the gold standard, and the gastroenterologists perform this, like Dr. Hong. Exam and blood work do not identify early stomach cancer, although there is some blood work being evaluated now. But if stomach cancer is found, or you can feel stomach cancer on an exam, it's in very advanced stages. I'm just going to breeze through this very quickly because screening guidelines do exist in Japan and Korea. They've had it for a long period of time. Essentially the program in South Korea has risk reduction of gastric cancer screening is greater than 80% for endoscopy, meaning that 80% of patients have been diagnosed with earlier stage cancers, reducing their risk. And then, we see that in Japan, they've had this for a very long time, endoscopy starting 2014 every 2 years. Usually every 2 years, greater than 40 years old, but this is probably going to be changing, less than 40, 50 or older. There's some new strategies going essentially for risk patients with H. pylori testing and offering endoscopy. So what has the screening programs done? Well, thanks to the Gastric Cancer Disparities Initiative. This is thanks to Dr. Huang's data that he presented before. But essentially what we've learned is that when Korea started screening over the years, the early detection of gastric cancer rates have gone up, whereas no screening program in the US, well, early stage has stayed the same. And I think this data is probably the same in 2024 from what we looked at in the National Cancer Registry. Just to show that if you have localized disease, your survival is better. So what happens in the US? There is a recommendation for breast cancer, colon cancer, cervical cancer, lung cancer, prostate cancer. As you know, if you are one of those people that go to the doctor regularly, you would be offered these things. But even if you're Asian American and you're over the 40 years old in the United States, you will not be offered a stomach cancer screening because it's not available, even though studies have shown that it could be cost effective. So what can we do to address stomach cancer disparities in the United States? well, we cannot accept any death due to gastric cancer because it's preventable and it can be detected early if we have the right program, identify high-risk patients. Like Tae Lee, who was a very young patient of mine who lost his life to stomach cancer. He's actually a Stanford Business School graduate, so it's appropriate. I thought that I would share the story like I did during the Stanford Gastric Cancer Summit. He had symptoms for a long time when he presented to the doctors and were prescribed antacids. No one suspected stomach cancer, even though he's a Korean American male with these symptoms. It wasn't until pain and weight loss got worse months later, and he advocated for himself to get an upper endoscopy. They found a ulcer positive for cancer. There was a delay in getting a CT scan, and then he was found to have stage 4 stomach cancer with peritoneal metastases. He fought very hard for about over 2 years, and he passed away. So what can we do? We should recognize that we are the fastest, Asian Americans are the fastest growing ethnic community, and that these cancer risks like stomach cancer that disproportionately affect us really matter, and that we should become an empowered community and recognize these things. While we have very few involvement in clinical trials, and the funding for stomach cancer is so low, and this all adversely affects us. So I think we should take charge of our stomach health. So for all of you, know your stomach cancer risk, minimize your risk of stomach cancer. Do not ignore symptoms associated with what we just heard about stomach cancer. We should get tested and get treated for upper endoscopy. For H. pylori, and then we should consider whether or not we should get an upper endoscopy at a certain age with additional risk factors. And for stomach health, we should, I feel like a doctor talking, but you should eat healthy and drink lots of water, exercise, get lots of sleep, and minimize stress, and quit unhealthy habits. Support stomach cancer research, so we can have more community awareness, education, advocacy, etc., more funding for trials, and eliminating disparities. I think I talked about this in the past, so I'm just going to go quickly through it. We want to seek congressional support, like Hope for Stomach Cancer has done, so we can get, new legislation focused on stomach cancer and ethnic health disparities elimination, get support from, be part of the moonshot, as there is 1.8 billion, over $4 billion allocated to this, and stomach cancer should be part of it. And just to share, we should continue to do studies. And I wanted to recognize Curate Research Foundation for understanding the importance of stomach cancer in our ethnic communities, and a study that is open at City of Hope for, early detection in high-risk populations for Asians, Hispanics, and Blacks. We want to identify, the goal of these studies and all of our studies should be to identify at-risk persons for gastric cancer screening. This is a map on the right. The pink map is the density of Asian Americans population. And this red blue map on the right of your screen is the incidence of gastric cancer. So if you live in California, you live in a very hot state with high incidence of stomach cancer. It's not a red state politically, but it's a red state for stomach cancer. And so we should have some direct community outreach for this. So just to go through, in summary, as I've discussed before, gastric cancer is diagnosed in late stages, and outcomes are poor in the United States. A rare cancer in general U.S. population. It is not rare in ethnic Asian Americans. Gastric cancer is the leading cause of health disparity, adversely affecting Asian Americans. H. pylori testing and endoscopy screening in high-risk populations can be cost-effective and save lives. take charge of our stomach health and act now. And I would like to acknowledge Gastric Cancer Disparities Initiative, led by Chuha Huang and Robert Huang, and myself and our colleagues, Dr. Kuo at Harvard University, and Hope for Stomach Cancer for supporting us. Thank you very much for your attention. Open for any questions.
Thank you, Dr. Woo, for that brilliant presentation. So at this point, if anyone has any questions, go ahead and feel free to put them into the chat. We've also had a number of questions submitted before this evening's talk. So I thought that, Dr. Woo, if it's okay with you, maybe I'll just pick a couple of these questions
Sure.
to get started with. Okay, so I guess as a surgeon, I'll first pick one of the questions that asks about surgery.
Sure.
So one of the questions asks, what are the outcomes after surgery? Do patients tend to do well up to 10 years following a surgical resection? Can you speak a little bit to what the patient experience is like after surgery? Do they have to change their diet? Do they have any, long-term changes to their digestive tract, to their digestion? And then what is the risk of someone getting cancer again?
Sure. So I think it's a very broad question. So right now there are three approaches you can do. You can have a big open surgery with a big incision, or you can have a minimally invasive surgery through laparoscopy with small incisions, or robotic surgery. So there are three approaches. And, there's some benefits and indications for each of those. I would say in general, minimally invasive surgery with robotics outcomes, cancer-related outcomes are the same as open, but their recovery would be quicker. So, and it different from, so patients who have very early cancers, because their cancer is completely cured and they have a very low risk of recurrence, actually patients actually do much better after curative surgical resection. Whereas if you have an advanced cancer, you would need to get chemotherapy, then surgery, chemotherapy, and the effects of the chemotherapy on top of the surgery can be a little bit more difficult to recover from. Patients who have tumors located in the distal stomach and have only a port of their stomach removed actually recover quite favorably and well, where they don't lose a lot of weight in the long run. They're able to eat and drink, very similarly avoiding some sweets. If you have a total gastrectomy, removal of the entire stomach, that's a very challenging quality of life change. You lose a lot of weight, you can't eat a lot. So, and it's very complicated. Nutritional deficits can happen for both. If you lose parts of your stomach, you may need vitamin B12 replacements. Becomes like a very patient-specific recovery. And yes, I've seen cancer recurrences happen at 5 years where we thought patients were cancer-free, depending on stage. And then at 10 years, you can still be at risk. If you have some stomach left, your stomach risk in that remnant stomach can also remain. If you can't eradicate the H. pylori, that means that you still have increased risk. And patients who've had some surgery in the past to remove part of their stomach and have a long-standing reflux of bile, also at increased risk of stomach cancer. So that's something to consider.
Right. Thank you. So we have a number of questions actually now about the role of diet in both the pathogenesis of gastric cancer and its association with H. pylori. And you and I were just talking before.
Yeah, I'm going to have to look up
this.
Google AI.
Yes. So I'm actually very, very curious about this. So I guess to summarize these questions, first, does diet affect your risk of getting H. pylori? And secondly, if you have H. pylori already, is there any association between diet and food groups and your risk of progressing on to cancer?
I'm not sure about the second portion, but
Let me tackle the second one then.
Yeah. So you can totally, yeah. So I think we should talk about how we get H. pylori. You know, unclean waters, somebody in your family has H. pylori, it's passed on from oral to oral, eat sharing foods. And so I think in that respect, H. pylori is like sort of an infectious disease that you can pass on from one person to other. When I saw the questions about, is there H. pylori associated foods? And I actually had to look it up online, to be honest. And it seems like there are, Google says, yes, there are foods associated with H. pylori infection, including like a lot of carbs in your diet, may perpetuate H. pylori infection, candied foods. And also uncooked foods may actually be harboring H. pylori because it's a bacteria. If you cook it, it'll probably die, but if it's raw, it's still alive. If it's not clean. So I think those are some of the things. So the second part I leave to you, Dr.
Sure.
Pong.
Yeah, so a couple of people asked, and thank you for submitting them. These questions is diet one of the main reasons why Asians have a higher disease incidence? So, how this topic is usually studied by epidemiologists is that we look at cohorts. So we send out surveys to say 10,000 or 100,000 people, and then we can link the people who return the surveys with later cancer data through, for example, the California Cancer Registry or other cancer registries. So the couple of studies that have done this have suggested that diets that are rich in red meat, processed meats, and high salt intake are associated with gastric cancer, but a whole range of other digestive cancers, as you might imagine as well, colon cancer, esophagus cancer. I think diets that are rich in processed foods, processed meats, and red meats are associated with a range of cancers, including stomach cancer. There seems to be a special role for salt intake. So there have been these very nice Japanese cohort studies that have suggested that if you were already infected with Helicobacter pylori, specifically a more kind of dangerous strain of Helicobacter pylori, which is very, very common in Japan and Korea, which contains this virulence factor called CAG-A, and you eat a high salt diet, there seems to be this synergistic interaction between the salt and the CAG-A, H. pylori, to really cause a lot of tissue inflammation and really kind of accelerates your risk for stomach cancer. So what I usually tell patients in my clinic is that the most important single thing is to eradicate H. pylori. But after that, you can cut down on your red meat, processed meat, and salted meats intake. Maybe try to eat more fresh fruits and fresh vegetables, foods with plenty of antioxidants, colorful. Maybe that might reduce your risk. Though there haven't been any kind of intentional clinical trials on this, as you might imagine, it'd be very hard to run a clinical trial on this topic. So now I've also got a number of really good questions about endoscopy. So someone said, an anonymous attendee wrote, for those that really fear upper endoscopy and the anesthesia, is there any other option, for example, barium, swallow, or guided imaging options? Another attendee asked, can a CT scan be used in substitutive endoscopy? Dr. Woo, if you could comment a little bit about, is there any role for any other testing aside from endoscopy for those who don't want an endoscopy? Is there anything as good as an endoscopy for cancer detection?
So I think in Japan, when they started their screening program in their general population, they did do double barium X-rays. You swallow a drink and they take a bunch of pictures and they see the outline of the stomach and the esophagus and the stomach to identify, and they were effective. However, the adoption of that radiologic or X-ray type of screening was only diagnostic of abnormalities in the wall, but you could not biopsy it to confirm a cancer. So I think over time, what has happened is that they've adopted the endoscopic screening.
Yeah.
And I will say that in gastric cancer for CT scan images, by the time that we see, and the general CT scan that we would get, like for any scan with an IV contrast and oral contrast, if you just do a regular one and it's read as, oh, it's normal, the stomach is normal,
Mhm.
doesn't mean that you don't have an early cancer. There was studies in the past where they did a double, where they, you had to blow up the stomach with
Yeah.
some effervescent gas and then did the study. It was able to capture some, but by the time you really see a cancer in the stomach on a
Mhm.
CT scan, it's
Mhm.
not an early cancer.
Mhm.
So they're
Mhm.
not that effective, unfortunately.
Right. Right.
And I know, Dr. Huang, we talked about during the Stanford Gastric Cancer Summit of, early detection blood markers
Right.
out there. It's just not all validated for early gastric cancer yet in the United States. So I
Yeah.
would be cautious to just do a multi-panel, DNA testing or something in the blood.
Yeah, I echo your sentiments entirely. I think that the future might be blood-based testing, multi-cancer detection testing, but I don't think we're quite there in terms of prime time yet. Early on, as you mentioned, the Japanese experience was with barium, double contrast barium, because well, this was before the age of widespread fiber optic endoscopy. The idea of everybody can just get a scope at any time really has only been the last 10, 15 years that's been economically feasible. For
Yeah.
back then, it was the only option. But I think that the limited data we have suggests that endoscopy really does have a better detection profile than barium or any kind of imaging.
And it's it can be definitive, right? Because you can do a biopsy and
Exactly.
show the cancer, whereas the
Exactly.
barium is an X-ray and it's suggestive, but it doesn't confirm a diagnosis.
Exactly. We got to also to kind of further that topic. Is there any AI software to help doctors to detect early stomach cancer in the U.S.? I can take that one.
Yeah, absolutely.
Yanghee. Uh, we're working on it, is the short answer. For colonoscopy, there's really actually good software. It's now actually licensed by the Medtronic company, and it actually has been shown in clinical trials to increase the colon polyp detection rate. So right now, there is a commercial product available in Japan. I'm not sure how widely it's used for cancer. For detecting cancer. And right now, that is not approved for use in the US. And there's also no device right now to detect the precancerous lesions. So these are the subtle changes before cancer. And of course, you're going to see 100 times more of that than you're going to see the cancers. I know there are groups that are working on developing AI-based endoscopic AI based algorithms to try to improve both cancer as well as the precancer. And hopefully those will be available in the US maybe in the next decade or so. And that's badly needed, as we talked about in our Stanford Gastric Cancer Summit last year. The US is really lagging in terms of our endoscopic training. Most of us in the US do not get a lot of training on how to detect these things endoscopically. Our mentors, our teachers are more focused on colon or Barrett's esophagus. So this is another area of healthcare disparity that we can really work on. I
Dr.
wanted to
Huang,
ask, sorry, go ahead, Dr. Wu.
I think that what you bring up actually, it touches on a really important point about stomach cancer care, gastric cancer care in the United States, because it is not a high incidence of cancer. The
Uh-huh.
experts in this field, like endoscopists, surgeons, medical oncologists,
Yeah.
um, are they're not everywhere in the United States. Unlike lung cancer, colon cancer care, and breast cancer care, there are many centers who can specialize in high incidence cancers, but stomach cancer care, I think, should happen, like endoscopies and surgeries and multidisciplinary treatment at cancer centers like Stanford and City of Hope and other places that have these experts in the field.
He or she asked, in someone with alcohol dehydrogenase deficiency, does persistent drinking create an extreme risk? I wonder if you wanted to take a first stab at that.
Yeah, so I don't know about extreme risk.
Uh-huh.
I think that it is one of the risks, that one of the factors that compound your risk.
Uh-huh.
So if you're Asian American, you have alcohol dehydrogenase deficiency and you drink a lot and you have H. pylori infection, you're a male over the age of 40 and
Yes.
you eat a lot of salty foods, then I think these are all compounding and a family history. So I don't know. I mean, when we were looking at the risk factors and looking at the relative risks and scoring them, there is a way to score to, make you at more risk. But I don't know that drinking a lot with alcohol dehydrogenase will make you get stomach cancer.
Right.
It's just one of the factors.
But in answer, also just kind of an aside, yes, the stomach cancer is kind of still, the jury's still out on that one. But for esophagus cancer, I think that is fairly well established. If you do turn red, you flush. I myself flush when drinking alcohol, and you drink more than 2 drinks a day, so that's 14 drinks a week. And if you're, say, in the workforce or you're business person, there might be a lot of social pressure to drink in Japan and Korea, as Dr. Woo knows. So, and there you definitely increase your risk for esophageal squamous cell cancer. That has been unequivocally proven. So I would say that for gastric cancer, maybe, but for esophagus, definitely. So if you turn red, please limit yourself to limit the amount of alcohol you intake. We actually have a scientist here, Dr. Chehong Chen, who feels very passionate about this topic. He feels so passionate, he actually convinced the government of Taiwan to create a no alcohol day, 无酒日, for those Chinese speakers in the audience, no alcohol day, or also May 9th, because they're homonyms. And so now May 9th is Avoid Alcohol Day in Taiwan to spread awareness of the dangers of drinking when turning red, drinking excessively when turning red. So really, thank you for that outstanding question. We got a couple of interesting questions actually about GIST. And I know that most of this talk was about adenocarcinomas. But Dr. Wu, I'm wondering if you could
Yeah,
answer these
I
questions.
saw
There's
that.
two
Yeah.
questions about small GIST. What do we do about small GIST? So these are under 10 millimeter GIST. What is the prognosis? What do we do? And this is actually a question that I struggle with myself as a clinician. What do you do when someone refers to you a 9 millimeter GIST?
Yeah, so NCCN guidelines and the studies show that just under low proliferative GISTs,
Mhm.
meaning that the cells are not dividing quickly, at 9 millimeters, almost all of them are very low risk GIST.
Uh-huh.
Under 2 centimeters, NCCN guidelines says we don't need to resect them
Uh-huh.
if they're found to be low proliferating. And so if you came to me with a GIST that was 9 millimeters, I would surveillance it. And I would not resect it. So that's just by the NCCN guidelines. If it were to grow over surveillance time, and usually they do, some of them just stay the same over many years. I have surveillance patients with like 1 centimeter just for like 10 years and they stay the same, and I said don't come back unless it grows. So 9 millimeter is an easy question, but if you have something borderline that is like 2 centimeters, then I would recommend resection. I mean, what would you do, Dr. Huang?
I think, so I have an easy job. My job is just to stick the needle into the GISTs and get the spindle cells out and then send it to our wonderful surgical oncology group here and make them make the call. So,
Yeah.
job is easy on our part. I will say that it's hard to sometimes get a diagnosis. So if it's really small, let's say 7, 8 millimeters, 6, 7, 8 millimeters, sometimes we just won't be able to get enough tissue for a definitive diagnosis. In those cases, we'll just bring them back in a year or two to repeat the endoscopic ultrasound to get more tissue.
It's a very low risk.
Yeah.
Studies shown anything below 2 centimeters, extremely low risk of you dying from it. And if you had surgery to remove it,
Right,
then you're completely cured. And your risk of it coming back is almost nothing at that size.
right, right. Okay, so then we also got a couple of questions about genetics and genetic risk factors. And so, I'll just read one of the questions, for example. How big of a role does hereditary play in gastric cancer compared to other types of cancer? Is there any genetic marker to test for?
Oh yeah, so for sure. I don't know. So in gastric cancer, only 3 to 5% of the cancers are genetically created, stomach cancer. There are many types of gene defects that actually lead to gastric cancer, but none of them are 100%. We used to think that CDH1, the gene that creates coherent, which is like a junction to junction a protein, if you had a defect or a mutation in that gene or a complete deletion, that everyone would develop stomach cancer. But now we found 100 variants of CDH1 mutations. And so not everyone has the same risk of developing stomach cancer with that risk. With that gene defect, CTNNA also is a gene, and then BRCA1 and 2 creates, risk of stomach cancer, Lynch syndrome, there's some other rare ones like, familial adenomatous polyposis with APC and MYH gene mutation. Li-Fermini syndrome, I think, is another one. And so most of the time as a surgeon, I see the patients with the CDH1 mutation because there is a recommendation for prophylactic gastrectomy if you meet certain criteria. I also see patients with Lynch syndrome because some Lynch syndrome patients have more predilection to have stomach polyps than some other patients with Lynch syndrome, and FAP patients who have multiple polyps in their stomach, and we have to decide what to do with them.
Right.
As colon cancer risk is also high, and they may be dealing with having colectomies and gastrectomies, and it's a very tough question to answer.
Right, right. If I might just add to that, we had a very fascinating lecture last week at the summit about so H. pylori runs in families as well. So it's one of those things where how do we determine what is shared genetics versus shared environment? I don't know if many of the audience knows, but and I didn't know this either. Napoleon Bonaparte, the famous French general emperor, actually died from stomach cancer, as did his father, as did his sister, as did his brother, as did like multiple members of the family. And they think it's probably because they all had H. pylori. They all kind of the same virulent strain of H. pylori. So especially in East Asia, when there's familial clustering of gastric cancer, it's not clear if it's because they share the same genes or they all have the same nasty strain of H. pylori. In the West, because the H. pylori prevalence is a little bit lower, when you see family clustering of H. pylori, you really do think a little bit more about the genetic aspect. I will say in answer to this question, there was a very interesting study that was published in the New England Journal last year, and where they looked at the association between certain genes, for example, CDH1, which we classically associate with a non-H. pylori pathway. So if you have CDH1, you're supposed to get a different type of, like a diffuse type cancer, which has nothing to do with H. pylori. It's not in the biological pathway. But actually there was a multiple fold increased risk if you had both one of these mutations as well as a H. pylori infection. So there may be something we don't fully understand yet from a biological mechanism standpoint about this very interesting interaction between genes and the environment. In the West, currently, there are certain criteria for testing, for genetic testing. If you have certain number of relatives of a certain closeness, kinship to you, that have gastric cancer before a certain age, then you should certainly talk with your doctor and maybe consider being referred to a genetic counselor for testing for one of these known pathogenic genes.
City of Hope because we see so many cancer patients. We have a study where all of our patients are genetically offered genetic testing and counseling.
Right.
But yes, it has CDH1 mutation, ctDNA, ctNNA. Those mutations, when found, are definitely counseled for risk of stomach cancer.
So we've gotten also a number of questions about timing of endoscopy. So I'll just go through a couple of these. So how often should ideally an asymptomatic Asian American get endoscopy? Several people asked about what is the appropriate kind of interval if you have a precancerous lesion to to get an endoscopy. For instance, if you have metaplasia, how often should you get endoscopy? If it's okay with you, I can tackle some of these questions.
Sure,
Dr. Woo.
absolutely.
As a gastroenterologist, this is something that we have to think about all the time. So I will say currently there are no recommendation to screen for gastric cancer among high-risk groups in the United States, which is unfortunate and might be changing very shortly. So stay tuned on that. But right now, there's no routine screening for stomach lesions, stomach cancer or stomach lesions. Now, if you have a stomach lesion, like precancerous lesions such as intestinal metaplasia diagnosed for some reason, let's say you had an endoscopy for a different reason, then what to do? So there are ways to risk stratify people with intestinal metaplasia or other precancerous lesions. We look at both the individual. So what are your, for example, what is your family history? Where did you immigrate from? Were you a heavy smoker? Things like that. So we evaluate risk at both the individual level and then also at the tissue level. So the tissue is very important too. Turns out that metaplasia can be very, very different in terms of the risk of turning into cancer. The really low risk, if you just have a little bit of metaplasia in one location, the stomach, like focal intestinal metaplasia and just the antrum. On the other extreme, you can have diffuse extensive metaplasia of multiple locations of the stomach, and on each biopsy piece, the entire biopsy field is just goblet cells is just metaplasia. So those two, the difference in risk between those two patients might be up to 100-fold. And so the limited data that we have suggests that not every single person with any metaplasia should automatically get screened. It should get surveyed. It really depends on, do you have extension? Do you have a lot of metaplasia, severe metaplasia? Do you have a higher risk variant of metaplasia? So I would say if you're diagnosed with metaplasia, it's certainly worth it to speak with a gastroenterologist or someone who knows something about this topic to figure out whether you need to be surveyed and what the appropriate surveillance interval would be.
So I'm going to go out a little bit on a limb to answer the questions from for Asian Americans living in the United States about what age. So in Korea, it's 40 years every 2 years. And in Japan, I believe it's similar, but the age is going to change because of the decreasing incidence of H. pylori infection. The average age of gastric cancer in the United States is 69 years old, but the average age of gastric cancer in Korea, for example, is like 55. And the studies have shown the reason the interval is every 2 years is because if you get an endoscopy, every 2 to 3 years, the chance of you never had a gastric cancer, the chance of capturing an early gastric cancer within that period is very good. If you had a endoscopy 5 years ago, the risk that if you developed early cancer within the next 4 years, the chance of capturing an early gastric cancer, if you do it every 5 years, is much lower. It's like 50-50. And then it becomes like 80% chance if you do it every 2 years. So those studies were done in Asia. And so every 2-year interval and that's mostly accounting for intestinal metaplasia changes. Of course, if to detect a diffuse gastric cancer, that's a little different. So I would say that you should start considering whether or not You should get an upper endoscopy at the age of 40, depending on your other risk factors. And if you're going to go get a colonoscopy at the age of 45, or even sooner, like 10 years before your like immediate relative had it, then I would say that as an Asian American, you should ask your gastroenterologist, can you give me an upper endoscopy? Especially if you had other risk factors. And every 2 to 3 years, if you maintain those risk factors as an Asian American male, smoking, drinking, family history, female as well. So something to consider and discuss with your primary care physician, your gastroenterologist. I think just keep in mind, once you start to turn 40, 45, 50, your risk is going up as an Asian American.
Yeah, absolutely. So we're coming up to the top of the hour here. So I think I'm going to probably cut off the questions here. I wanted to thank Dr. Woo again on behalf of CARE for presenting tonight. Thank you, Dr. Woo, for a really enlightening scientific presentation. I thought that this interaction, this question and answer period was very lively. We got a lot of questions. Clearly, this is a topic on a lot of people's minds, a lot of Asians' minds, and as it should be. And I think that this is a very exciting time to be in this field, as you and I are, Dr. Wu, because the guidelines are changing. The science is, as we saw last week, the science is also rapidly evolving with, for instance, some of these, these non-invasive detection tests, the science of metaplasia, and I think moving in the right direction very quickly. Dr. Wu, any final comments before we wrap up here?
No, I want to thank everybody for joining and the opportunity to really discuss this important topic. And always remember that, we want to have stomach cancer as part of our minds and our health as we go forward. So thank you, CARE and Dr. Huang, for this, wonderful opportunity to discuss this in this forum.
Wonderful. Well, thank you all for attending, and good night.
Good night.